So one bit I want to touch on now is we've touched upon about living with risk. Obviously, Lindsey, you've talked about how your lifespan. Obviously, you had surgery from a young age. How do you? Obviously, you said about your well-being as well, but how do you continue to moving into the future? How do you continue to kind of manage that?
Well, it's interesting. Obviously, it slowed my career. You know what I mean? I did have a stroke 9 years ago. I had some more extensive back surgery at that stage, and I had to slow down. I had a corporate job. I was, you know what I mean, very busy. But in a way, it's given me the freedom to do the work that I'm doing now as well, you know what I mean, on the patient side, which I'm actually very thankful about. I would still be, working for a giant bank in Canada if that hadn't all happened. So that happens. It does get more complex. It does require, just like everybody, we're all aging, you know what I mean? We're all going to age. We're all going to deal with age-related disease and disability potentially. It's just happening sooner. And for a lot of people who have dealt with aortic dissections, some of those same things, it's just sort of, some of those things have happened, sooner, and they've had to slow down. So I've talked about this with Gareth about the concept of grief. And obviously, when it comes to Think Aorta, we talk about, the grief of the people who've been left behind, who didn't survive. That is, one very significant part of the grief story. I believe the other story is about grieving for the previous you. Mm-hmm. And if someone with Marfan syndrome, I've gone through significant phases of that where, you know what I mean, I had a certain functionality, whether it was eyes, vision, what I could do physically, how much stamina I had, how much I could work, all of those things, where I've had to stop and take stock and evaluate, you know what I mean? Why is this bothering you so much? Because you do have to go through a grieving process of what you've lost.
Yeah, adjusting to your new normal, isn't it?
Exactly. Yeah. And then adjusting yourself into what are your new, your sort of new abilities in a way, and using them differently. So I've always sort of joked that, my body is in phase 3. So there's, Lindsey 1.0 was sort of before, was
a new model's come out.
Yes, Lindsey was before my big 2 aortic surgeries in late 20s. Then that was Lindsey 2.0 was born then. So then Lindsey 2.0 went till about 45 when I had my stroke. And now I'm into Lindsey 3.0. You see, this is the 3.0 version of me. Yeah. And she's a bit different than the old ones. Of course, she can't do all the same things. However, I think I'm doing things that I wouldn't have done then. Yeah. So it's embracing that part of your life and understanding yourself in a different way. And I do people with, people who've been relatively healthy or felt that they were quite healthy in their lives, have a sudden event like an aortic dissection. That's a lot. And you have to grieve who you were and you can't try and go back. There is no going back.
It's the new you rather than trying to fight to find the old you.
And in the stroke world, that's a very, a thing that they talk about is about that. You can't go back. You don't get that bit of brain back.
No.
You know what I mean? I've just got some new bits now that, neuroplasticity is my friend. So, so you have to think like that about how to build, who is this new phase? How do I make this work for myself? Mm. And that's, the positive part of working with somebody, even talking to friends, talking to people who you just know who have gone through it, I think really help to highlight, maybe you can't, drive anymore here, just as a small example, but it does open up different ways to access the world. And with the right mindset, you can really flourish in that understanding, and you bring something else to the table then. So I believe that, we live with fear, we live with grief, but the thing that's going to save us is hope, and hope is what we're doing.
Yeah, that's a really nice message to finish on that one, isn't it? Gareth, what about yourself, kind of living with risk? You actually talked about one of your children, so your son, isn't it, has got Marfan. So it's not actually only you living with risk, isn't it? It's almost like supporting your family potentially living with risk as well. How do you kind of see it?
My mum, obviously, after what happened to my dad, was terrified that something bad like that was going to happen to me.
As you would be, wouldn't you?
Yeah. So she kind of wrapped me in cotton wool, and and I wanted to be having adventures. It was really challenging. And I was talking to somebody else with Marfan's the other day, actually, who's a similar age. And she said, oh, yeah, I'm an only child with Marfan's. My mum wrapped me in cotton wool. And we were comparing notes on the things we did as teenagers that we didn't tell our mums.
Was it a long list?
Was it? And for her, actually, skydiving was on the list.
Oh, wow.
So, she had a gap year and went skydiving. But I think so. Part of my attitude was, as I said, I believe you can live a very fulfilled and successful life with Marfan's. And so I didn't want to wrap my son in cotton wool the way that I had been. So
that must be quite hard, though. I'm just thinking, because I'm a parent, and my children are a lot younger, obviously, but the fact that there's this element of risk to them, you want to kind of wrap them in cotton wool, don't you? So it must be quite hard to, even though you've got that in the back of your mind, just saying, like, I was wrapped in cotton wool, I don't want that, but also you want to look out for them as much as you can, don't you?
Well, I think it's looking out for them, and there's preventing them from doing things that they should be allowed to do. So, we made sure that my son got access to decent medical care. He had a lot of eye issues to do with Marfan's, so he had, really excellent care from Moorfields Eye Hospital in London, and it still goes there, actually. So, and they also did my eye operations, so we've both benefited greatly from the team at Moorfields. Very grateful for that. So we made sure that he had access to that. He had access to cardiology surveillance. That's pretty much what he needed. But other than that, he did what I did and joined the Air Cadets. He was travelling internationally. He was flying gliders and aeroplanes. He was doing adventure training in his Duke of Edinburgh's award.
Yeah, wow.
He's 26 now, but even went to university, had a great time, got a job, and then last year said to me, "I'm climbing Kilimanjaro this summer, Dad, with a group of friends."
Wow.
And I'm like, "Yeah, go for it. Go on then." Because they were taking a medic. It was an organised tour. They were taking a medic. He's very sensible.
Yeah.
Told the medic about Marfan's, had an assessment, went up, and I have a wonderful picture. He's 6'5" because he has Marfan's.
Yeah.
A wonderful picture of him standing on the top of Kilimanjaro with his walking poles above his head, because he wanted to be the highest thing in Africa at that point.
So that was his claim at that moment in time. He was the highest thing
in Africa.
In Africa. Straight on the CV.
Yeah. So I think it's a balance. You have to find the balance. But I was like him when I was his age. I just wanted to get on and do things. I didn't want to give in and be kind of limited by Marfan's. I did the healthcare appointments.
Yeah.
But my experience of Marfan's in my first 40 years was it hit me with something acute every 10 years. And the rest of the time I was able just to get on and enjoy life.
Yeah, it's like just a barrier, right? We're getting over this barrier.
It's a part of you, I think, and it's just having a strategy to manage it.
Yeah.
And as Lindsey said, I had medium Marfan's, I suppose. Some people have very severe Marfan's.
Yeah.
It's a spectrum depending on how the gene expresses itself. But so I think the main thing to do about risk is make sure you're getting the medical care that you need.
Yeah.
And get it from decent specialists who know the condition.
Yeah.
If you're doing that, then your quality of life will be higher and you'll be able to do more and take more risk in the rest of your life.
And having that frequency of, them reviews and things like that, not leaving it years and years and years and years maybe before checking in on them specialists.
Absolutely. Most people with Marfan's have annual cardiology surveillance. That's entirely appropriate.
Yeah.
When my eyes were playing up, I used to be every 6 months or every year to Moorfields.
Yeah.
But then they did all their surgery and I kept going back every year for the first 15 years. And they said, "Oh, well, you don't need to come back anymore, Gareth. You know where we are if you get a problem."
Brilliant.
So I think different people, risk is a personal thing. Different people have different attitudes to it.
Yeah.
But you can, if you empower yourself and get the care that you need, then it enables you to do a lot more. And some people just aren't able to access what they need, So the majority of people with Marfan syndrome in the UK are not even under surveillance.
And that's scary, isn't it? To think about all the support that you've said about, what you've accessed and, what you think is needed to limit that risk. Actually, some people they're falling through the kind of cracks in the system potentially, aren't they?
And this is probably, I know we're going to talk later about messages to doctors, but one of my messages to the health system is this: care about the patients that you don't see as much as the patients that you do. Because access is a huge issue for people with rare diseases.
Yeah.
And I know healthcare resources are stretched very thinly, but that's not a reason for denying people access to the care that they should be experiencing, So it's good to see Marfan clinics, aortic clinics being set up. It's good to see units kind of reaching out and trying to find more patients.
Yeah.
But I think in healthcare, it's too easy just to be reactive and treat the patient who comes in the door and not worry about the other 5 who've never made it.
No, it's a really good message. I think because, especially in the UK for the NHS, we always seem to be stretched, don't we? The mindset often is reactive, isn't it? Rather, if you put in the infrastructure to then, try and prevent in the first place, the focus is then not on reacting, but actually helping people at an earlier point in their time, isn't it?
Well, from an investment point of view, if you take somebody with Marfan's and you identify the disease, you screen their family to identify anybody else who's got it, you put them on a surveillance pathway, and you invest in surveillance and prevention. Somebody with Marfan's, if you don't do that, is going to cost the health service an awful lot of money.
Yeah.
So the business case is pretty obvious to me that if we do it, we prevention is going to save the NHS a lot of money and a lot of time and resource.
Yeah.
So it's a good place to invest.
So I think now we've summarised and talked about risk quite a lot. I'd quite like to kind of move us on now to about prevention of dissections and kind of, especially obviously like in your case, Gareth. So if we start with you, Gareth, what kind of, is there anything key that you think is really the key to prevention of a dissection?
So if you think about aortic dissection, a percentage of patients have a risk of dissection that is genetic, like Lindsey and I have in Marfan's. Marfan's is the most well-known one, but there are, I think, about 37 genetic mutations now that we know about that confer a risk of aortic dissection.
Yeah.
So, and because genetics is transforming our understanding of this disease, so it's possible that many, many more dissections are genetic in nature, and we just don't know about them yet. So screening for genetic risk of aortic dissection in families is a really important intervention. So we have a campaign called Think Aorta, Think Family, which is about educating families to talk about aortic disease like they talk about cancer and heart disease and diabetes in their family. So if families are talking about it, the next step is the access step. How do we get them access to screening? There are inherited cardiac condition clinics around the country who will refer people for genetic testing if they think they've got Marfan's or another genetic aortic disease. But there is a problem of access. Most GPs don't even know that aortic disease can be genetic. And we did a Think Aorta education session for GPs last year, and a GP phoned me the next day and said, I had a family in my surgery today, and I've referred them for genetic testing. I never would have done that if you hadn't taught me that aortic dissection was a genetic disease.
Wow.
So I think we need to address this whole access issue, screening of people, and put them under the right surveillance.
Yeah.
Because we've got the cardiologists, the drugs, the surgeons who can provide elective treatment. And as we know, elective treatment is far more cost effective and far lower risk than emergency treatment.
Of course, yeah.
And gives the patient a better quality of life usually as an outcome. So I think it's time that we invested as a nation in screening and surveillance to pick up people at risk of thoracic aortic disease. And then I think if we did that, we would probably put a cohort of 25,000 people on a surveillance pathway and prevent a lot of dissections. Yeah. And the charity Aortic Dissection Awareness UK and Ireland runs a strategic national research programme in conjunction with the University of Leicester, which I lead with my partner, Professor Gavin Murphy, who's an academic cardiac surgeon at Leicester. And we have a 5-year programme running to look at screening and increasing uptake of screening to put patients at genetic risk of dissection on a surveillance pathway. But we can demonstrate, we can devise the evidence and provide the evidence for why we should do that. Yeah. And then we need to change the NHS so that it happens.
Well, hopefully, obviously, once the screening project is concluded and the results we hope, but will be supportive of obviously the suggestion, then that will hopefully inform that evidence-based change, won't it?
Yes, I think so. And I think the whole research project is being conducted with a view to implementation.
Yeah.
Because that will save tens of thousands of lives.
Yeah. Just going back very quickly, what I really liked there is about when you said about the educational session for the GP as well, and actually having that call the next day to say if you wouldn't have done that, which I think links really nicely to Think Aorta. And the whole point of that campaign, isn't it, is to get people to change their mindset a little bit, isn't it, in terms of thinking about dissections, genetic conditions, Marfans. So that I know, obviously, I've taught a lot of paramedics here now and across the country. Obviously, we're doing primary care sessions. We've got ACPs and EDs, nursing teams, doctors. I think all these people we can influence really, and that's just one example of many, I'm sure, actually, where people have said, actually, because of your session, we've actually recognised a dissection, or we've referred someone for genetic screening, and hopefully supported more people in the long term.
So I think there's some wonderful anecdotes and stories of people whose lives have been saved. My friend Simon Jones does a talk that says, it's titled "Last Night a Poster Saved My Life." And his story is simply that somebody diagnosed his aortic dissection because a few weeks before they'd read the Think Aorta poster on the wall of their ED.
Yeah.
So there's some great stories like that. Maybe we should get him on the podcast, actually.
Yeah, sounds great.
It's a good idea. And secondly, though, we now have data to show that Think Aorta works. So the National Adult Cardiac Surgery Audit for 2023 looked at people having emergency surgery for type A dissection. And it showed that over a 9-year period, the number of cases of people having surgery had increased 68%. That's 250 more people a year having surgery for type A dissection. And then, obviously, being good scientists, the auditors said, why is that? And they looked at it, and their narrative conclusion, you can read it in the National Cardiac Surgery Audit, says, this is not an increase in the prevalence of the disease. There has been a campaign called Think Aorta, and we think that the increase is likely due to the success of the Think Aorta campaign. 68% increase in people having surgery.
Yeah.
So I try and picture sometimes 250 more people a year walking around the UK.
Yeah. Or if you just put them in a room and you walked in and had 200 odd people, like, it's crazy, isn't it?
That's the impact of Think Aorta. And what it does, wherever you work in medicine, pre-hospital or wherever, the point is to change the old thinking into the current thinking. There's a lot of old thinking. The old thinking is, aortic dissection is a terribly rare disease, and you'll be very unlikely to see one in your career. Now, the data is that aortic dissection kills more people in this country every year than road traffic accidents. Yeah. Right? We don't tell ED clinicians or paramedics, you will never see a road traffic fatality in your career.
No, we don't know. I'm just thinking about our students in year one. We literally have a whole road traffic collision day where they go and cut people out of cars and learn to deal with it.
Exactly, So that's a very stark comparison where more people die of dissection, but it doesn't get the same attention.
Yeah.
So that's my answer to people who say, this is a very rare disease. And then the second thing people often get taught is, well, even if you spot an aortic dissection, you can't do much. These patients don't do well. Hello, I'm here. Look at me, 8 years on. Because I got the right care, because I got the happy path. And so the point is, if we think aorta and put people on the right pathway, we can have great outcomes with 21st century medicine and surgery. Yeah. And that's the second point of, let's change the old thinking into new thinking for everybody working in the system. And we will transform this disease. Yeah. And in 20 years' time, aortic dissection will have changed from a cardiovascular catastrophe into a preventable disease. Yeah. That's my vision.
That's the goal. Lindsey, I just want to come to you now in terms of the question that I asked Gareth in terms of prevention. Just thinking, obviously, you're in a different country, in Canada, a different healthcare system as well. How do you kind of look about going about kind of preventing preventing something like Gareth's been through, for example?
Well, it's very similar. Obviously, we have a national health system as well. Not exactly like the NHS. Obviously, we've got a massive country and not as much population, and different provinces and all of those factors. However, we do, we are a public system. So we have the same challenges in a way as the NHS as far as, healthcare and providers and waiting for surgery and all of that. Obviously I just like Gareth, genetic testing. Like we have a very similar mindset about the organization that I'm with, Genetic Aortic Disorders Association Canada. We actually are very active with something called MAC Aorta, which is a international registry for people with genetic aortic diseases, to also help research find the new genes. So part of our remit at the moment is to make sure as many Canadians as possible, genetic information is part of that registry. So people who are newly diagnosed or had a dissection and then have genetic testing, but also all the cohorts of Canadians that would have been identified from a syndromic point of view, having a disorder, but have never had genetic testing. So we're in the same boat a little bit where, getting the genetic testing is a bit of a challenge, and we're having to lobby the healthcare system to make that more accessible.
Yeah.
We have some of those same challenges, but that's something that we, understand that's going to change the face of people knowing that they have the risk and can get care. I do think also with Think Aorta, the increase of 250 more people each year potentially in the UK have been saved and had surgery. It's also the organic broad spectrum awareness too, that you're not going to even know the effects yet for 10 years on, 20 years on, because their family has been screened, so they've prevented, family members, because they've had testing or they've been identified, they realize they've got aortic risk in their family, they're just going to be more proactive. Yeah. And also their healthcare providers, obviously, hopefully, will also be more preventative with their care about the aorta. So I think we're just at the beginning of potentially seeing more and more awareness for everyone in general. You know what I mean? It has a long-term effect.
Yeah.
Hard to measure, of course. There's always going to be stuff that's hard to measure, but we'll know more. Just even anecdotally, we hear it from families who have, oh yeah, my sister now, we know she has Loeys-Dietz syndrome, for example, or, my dad died of a dissection, so now we're all being screened. So that is, to me, that's very preventative. The other side is someone who has Marfan. It's also take your medication. You know what I mean?
Doing the fundamentals.
Do the things, because we do take certain medications to help prevent and protect the aorta. So there are reasons for that, and you know what I mean. There is good science behind some of those, and you know what I mean. It's not always great. It does make you feel tired and lethargic, and you have to live with those things. But, again, maybe I'm an example of that. I've taken my medication for 35 years, my beta blockers, and I have not had a dissection, and my aorta is normal sized at this point in time, other than the part that was fixed at the top. So, you know what I mean? So it's it's not great. It's annoying, but you know what I mean? Compliance from your healthcare guidance is also incredibly important from a direct preventative point of view, and going your scans and all of those things, of course.
I think it really can't be understated about just doing the basics well, isn't it? And taking like we laugh about it, just taking your meds, it seems like a really logical thing, but the amount of people, I know, as my experience as a paramedic, going to people like, oh, you're taking this medication. Well, sometimes you're like, well, that's not really what the idea of the medication's for. It's not kind of selective. So compliance and actually helping yourself in that regard is actually really important, isn't it? So, and as you said, obviously it's helped you for such a prolonged period of time to, fortunately never have a dissection. So that is brilliant.
Yeah.
You touched upon a bit about, obviously, the work you've been doing. That kind of draws me nicely to our next point. So talk to me about Think Aorta Canada.
Oh, so we just launched Think Aorta Canada. And Think Aorta Canada, especially in Canada and the charity that I work with, fits very directly, especially the Think Aorta, Think family, the genetic testing part of it. Because to me, like the dissection itself is the event that we don't want to have. But when it does happen and someone gets the right care from a great surgeon and they survive, let's make sure that, this doesn't happen to anybody else in your family, and we understand why it happened if we can. We're not always going to find out, because not all of them are of a genetic cause, or we don't know them yet. But we need to do that part. So that is why in Canada we've launched this for the same reason that we want to make sure that people who show up at ERs in Canada have a quick recognizing, and like identified diagnosis and a scan. So, and for the exact basic reason why we did it, you guys did it here, was to make sure that, like, let's check the steps. Let's not just say, oh, you might be having a heart attack. It's not that, off you go. People have been sent home too many times, even with people with Marfan syndrome who they didn't know they had yet. So we have to increase that base rate that people are getting care, because we don't know about all the people who went home and died. So we don't necessarily have that data. All we have is the data of the people that we've, got, and we need to increase that because we know there's more. Everybody you talk to, clinicians will acknowledge that there are more, but we just didn't save them, or we didn't know. So we just, we have the exact same challenges as the UK, and it's really important. And also just a general awareness of what the aorta is to the general population is also helpful. So the more we talk about it, whether it's in the media or put up a poster, if they just happen to see one that says, oh, what's an aorta? It's just those conversations with other people. It just slowly, online, in the grocery store. Gareth can tell you how someone asked him about it in the Canadian grocery store. You know what I mean? It's one of those things that, even some of my own family members don't really know what your aorta is. So we spend a lot of time. You feel like you're a bit of a broken record because you have to tell the story so many times, but it's important, and we know that. So that's why we're doing it.
Yeah, it's interesting, isn't it? I think when I talk to people, and obviously I've not got the lived experience of you two, but just from an educational background and a clinician, I often say to people like, oh, well, the aorta is like the biggest artery in your body. And they go, is it? Yeah, so every other organ you've got in your body is, the blood, where do you think it comes from? It comes from the heart. And then they go, oh, I didn't know that. Yeah. And you're like, oh, well, it's quite important, the aorta, like when you speak about it like that.
There's been a really interesting development internationally, actually, this year about that. So one of the things we love doing is working with the medical profession, with some of the experts, to improve guidelines on aortic disease. And the Society for Thoracic Surgery in the US, which is the biggest global thoracic surgery organization, very well respected, together with the European Association for Cardiothoracic Surgery, published new international guidance on aortic dissection in March this year. And for the first time, the approach that they've taken is to define the aorta as an organ in its own right. So the aorta is now an organ, and that leads to, over time, healthcare saying, how do we treat this new organ? Do we have aortologists who specialize in it? Is there a field of aortic medicine that we need to develop people in? So I think that move by two of the leading surgical societies in the world to create the aorta, the organ, is going to change things quite a lot and result in a lot more interest in the aorta, a lot more understanding of the aorta. So that's really a landmark moment. Just happened 2 months ago.
Yeah. Well, and that obviously you said about more kind of interest, like potentially research. Obviously, if it's classified as an organ, probably more research, more potentially grant money available, and more focus, hopefully, to then, I think develop that knowledge base even further, isn't it?
Yes. Yeah, absolutely. So I think it's great to see that when you start with a little spark, and fan the flames, how this all grows and how people in the medical community respond. And I've had people say to me, this problem of aortic dissection that you guys are highlighting has needed sorting for the 25 years that I've been building my career in cardiac surgery. And you think, well, that's great to hear that the patients have been, and Think Aorta has been the catalyst for actually starting to deal with that and creating the global activity around this. And there's so much global activity now. So, I should just say Think Aorta, just to add to what Lindsey said about Canada. Think Aorta started here in the UK. It was a partnership between Aortic Dissection Awareness, the patient charity, the Royal College of Emergency Medicine, the Society for Cardiothoracic Surgery, and Heart Research UK. Yeah, those are the 4 organisations that started.
The founding members.
Founding members, And I still am just so grateful that as a bunch of patients, we knocked on the door of 2 very esteemed professional one Royal College and one professional society, and said, can you help us? Can we partner to do something about this problem? And both of them, we were knocking on an open door. And from the level of the presidents down, embraced the campaign and supported it and endorsed it. And you'll see their logos. We've now got the Royal College of Radiologists supporting the campaign. We've got the Vascular Society supporting the campaign. We've got professional societies in other countries supporting the campaign. But that's who it started with, was AD Awareness, ARChem, SCTS, and Heart Research UK. So that was in 2018.
Mm-hmm.
And the campaign has been so successful that other countries have started approaching us saying, we've got the same issues, can we take Think Aorta to our country? So Lindsey approached me a couple of years ago, said, can we bring that? And I'm delighted that she, as the patient leader of Think Aorta Canada, and GADA, the organisation of which she's president, have embraced Think Aorta and said, we want to bring this to our country. We've done the same in the US with an organisation called Aortic Hope. But the campaign now is truly global. The Think Aorta poster is available in the native language of 50% of the world's population. English, French, Spanish, Malay, Chinese, Catalan, Portuguese. So every country we go to, we do a medically approved translation of the poster. So 50% of the world's population can now read it in their own language.
That's incredible, isn't it?
Yeah.
Consider where you said obviously where the origin of the campaign has now come from to the growth in I would actually say quite a relatively short space of time as well in terms of medical kind of developments. That's incredible.
Yeah, it's been it's been 6 years. So this year we run a conference every year called Aortic Dissection Awareness Day, which I know you come to, Simon. It's always good to see
that'll be my 5th year this year, I think.
Yeah. So this year in Edinburgh, we've managed to bring in people from around the world. So actually, the Think Aorta campaign leaders in Canada, in the US, in Brazil, and in Malaysia are all coming to the UK to have our first meeting, getting all of the first in-person meeting.
That's amazing.
Getting all the campaign leaders together. So that's going to be another springboard for doing more.
Yeah.
We're currently talking to another 8 countries who've expressed an interest in taking Think Aorta to their countries as well. So it's fantastic that this campaign that began here with patients and clinicians in the UK and professional bodies is saving lives in so many other countries. And it's something that we in the UK can be very proud of, that we created something that is saving lives around the world. So I'm amazed at how it's grown in 6 short years.
Yeah, no, that is it is amazing. Obviously, I think just the growth in that short time. And I didn't realise actually just the amount of countries were involved now. It's gone so quickly, isn't it? The amount of, and you see on a further 8 looking to take that as well. And it's a really example of what the power of patients can have, I think, and obviously teaming up. And I credit you for going to these quite big organisations in terms of royal societies and things like that, and getting them on board, because that's no easy challenge either, is it?
I mean, the medical profession has been very gracious and very open.
Yeah.
But as I said before, when you come from a perspective like mine, which is healthcare should be listening to patients.
Yeah.
That gives me the confidence to knock on the door of a professional society and say, I'm a patient and you need to listen to me.
Yeah.
And with very few exceptions, I've found that these organisations have welcomed us. And when we've explained what Think Aorta is about, said, that's absolutely something we want to support because it's a problem that needs solving.
Yeah.
So, on it goes. And I think what we're very fortunate to have is patient leaders like Lindsey in all the countries that we've been to.
Yeah.
Because actually clinicians are great for giving the campaign credibility and advising us on what we should do, but they're very busy people.
Yeah.
A lot of us patients, have time on our hands where we can actually do the day-to-day driving of the campaign and networking and influencing and social media.
Yeah.
So we always advise countries, find yourself a patient lead and a patient team to actually be the catalyst and the resource behind the campaign. And the countries that do that seem to fare better than the countries where the campaign is just clinician-led.
Yeah. Well, I think for me, obviously just working with you in the years we've worked together, the patient kind of lead and the charity they're the driving force, aren't they? Yes, they need some help along the way, but actually they are the passion and the energy comes from that side, doesn't it? Yes, the clinicians like myself will want to help along the way, but the day-to-day is, I think, definitely more successful when you've got a patient driving.
Yeah, it's our disease.
Yeah.
It's part of who we are. And so you will not find anybody more motivated to make change happen than somebody who for the last 50 years has been affected by Marfan syndrome, or somebody who's had an aortic dissection.
Yeah.
And that's a resource the healthcare system doesn't really know how to harness. And patient charities do.
Yeah.
So this is why empowering patients and involving them, I mean, everybody who works for us with Think Aorta or in Aortic Dissection Awareness Ireland is either a patient or a relative of a patient who's got lived experience of disease.
Yeah.
And being in that position gives you real patient power and an incredible personal motivation to make a difference in your disease. So I think the clinicians that we work with know how to harness that and appreciate its value.
Yeah. I agree. So I think we're nearly close to drawing the episode to a close. So it's been great to have conversation with you. As I said before the podcast, there's a couple of things I'd like to really finish on, and they are kind of golden nuggets for the audience to take away. So whether they've, watched the whole podcast or just caught the end, it's what can they take away? So my first question, and I'll start with you, Lindsey, if that's okay, is if you're a healthcare professional watching this, what kind of golden nugget, what piece of advice would you give a healthcare professional?
Listen to the patient. That's really fundamentally, you know what I mean? Especially at a certain age, I have 50 years of lived experience living in this body. I know what it does, what it doesn't do, what's happening, how it feels to me, also how I've had to navigate the healthcare system fundamentally, which always has challenges in any country. I think that listening to your patient, especially with something this complicated and a chronic illness, is essential. And it's actually, I think it's the key to good care. I believe that there's a collaborative element that we need to harness more, and less about just, I'll tell you what to do, just do it, and don't you know what I mean? Don't ask any questions. That it's old school, and that I don't think it serves anybody anymore. I think it's incredibly important to listen to a patient. Yeah,
being patient-centered is so key. And that's what we also try to tell students here, but sometimes it's not always, what is practiced necessarily. What about yourself, Gareth? What would be your kind of gold nugget or bit of advice for healthcare professionals watching?
Okay. To healthcare professionals, I'd say this, look at Lindsey especially, not so much at me. But patients with genetic aortic diseases, patients who have aortic dissections, can have great outcomes and a really good quality of life. That's the 21st century reality. If you as a professional do the right thing for these patients, give them access to the right care, provide for them in the right way, we can deliver great outcomes in aortic disease. And that's different to the situation 20 years ago. So update your thinking, think aorta, and help us to care for these people and give them longer, better quality lives.
Yeah, really important message. And then the other kind of aspect I wanted to cover is, again, in terms of advice or gold nuggets, but actually for anyone who's going through or, has just been diagnosed with Marfan's or has had a dissection, either themselves or maybe that you're a relative watching, and obviously you want to learn about supporting that person. So Lindsey, we start with you. Is there any kind of best kind of advice you would give as someone who's obviously got lived experience to someone else?
Yeah, it's obviously creating, finding your network and finding your support network, because I think, as I said, we did not have that, and we didn't know we didn't need it. We needed it, but we did need it. I think it would have enhanced my choices and the way I navigated my life a little bit. I would have great value from knowing that I wasn't alone. You felt very, very, very alone. And even now, and the irony is I know a lot of people, obviously, and I've got a great network. And there are still moments where it can be quite isolating. So reaching out is the best thing you can do, especially if it's, say, a family a child has been diagnosed. Reach out as a parent and make connections, because they are going to be the source of, it's not so much, and I don't say it more from a support group point of view, even just the education and the lived experience knowledge that is passed online is incredible. Yeah, you obviously have to make sure it's medically vetted and that, you know what I mean? Talk to your own doctor, all of those important disclaimers. However, these are people who've done it, lived it, and understand it. And so that is going to give you the most real life view of how this can progress and how to live a you know what I mean, a good life.
Yeah. And probably going back to your earlier kind of note where you said about the new version of you, probably help them be the new version of them as well, isn't it? Be the John 2.0 or you know, whoever that person is.
Yes.
I think that's probably a nice way to look at it.
One of the most amazing things that ever happens for me, I remember the first time I met somebody with Marfan syndrome. I was maybe 24, 25, and I met one person, and unfortunately she didn't make it out of her 40s. But now, as I go to conferences and GADA in Canada, we are involved in sort of yearly conferences for patients, is when I meet that teenage girl or boy who have been diagnosed, and I'm the first person they've ever met with Marfan syndrome or anything related to what they have. I know how important that is, and you know, you just hear these anecdotes from their children. They'll be like, "Oh, Mom, it was so great to, you know, hear Lindsey speak or meet her because I can have a life like that. My life can be like that." And I'm like, absolutely. So it's having examples that are, you know what I mean, that aren't just about the medical, they're about the living part.
They're real examples, aren't they? That's the important. They're real life examples. And in a way, this role modeling for them people as well, isn't it? To see people like yourself who have had, you know, very full, joyful lives, but yes, there has been hardship, but you have to build skills to, like you said about resilience is key, isn't it?
Yeah. So that actually, every time that happens to me at a conference or I meet somebody new who's, I'm the first person they've met, and then we connect, and it's just almost relief that you can see in their faces that they've met somebody, and you're like me. I can see that you're like me. We're not, you know, we've got different lives, but we understand each other fundamentally in a level that you can't really explain. Yeah, it's fascinating and so fulfilling as a patient and as an advocate doing any work like this. That's why I keep doing it, of course. Yeah,
it's great work. Gareth, what about yourself? Any kind of golden notes or bits of advice of people going through this or relatives supporting someone?
Yeah, so patients and relatives of patients, I'd echo what Lindsey said, which is you're not alone. We'd love to meet you. Actually, there are lots of support groups, support organizations. What I'm going to do, Simon, is ask you to put a few links to them at the end of the podcast so that we can. So have a look at the end of the podcast, because there you'll find links to the Marfan Trust, the Marfan Foundation, the Aortic Dissection AD Buddies Group for Aortic Dissection Survivors, GADA Canada. There are organizations that are there to welcome you and support you. Come and meet us and make some friends, because actually the difference when you make a friend of somebody with your condition is life enhancing, right? And the single biggest thing you can do is find somebody else who's going through what you're going through and start to talk to them about your shared experiences. If you've got a diagnosis of a genetic disease, if you've got a diagnosis of aortic disease, if you had an aortic dissection, it's not the end. It's just the start of a new you, Lindsey 3.0 or whatever.
Yeah.
And it's not what happens to you in life that matters. It's how you respond to it. So if you surround yourself with knowledge and support, actually, we as a community will help you to get through this and live your best life despite what's happened to you from a health perspective. We're all in it together, and hopefully Lindsey and I are examples of how well it's possible to do, even if you've got a diagnosis of one of these diseases. So come join us.
Lovely. Thank you. Well, I think that pretty much draws us to a close. A really nice couple of messages to finish on. So if you've enjoyed watching the podcast, please do drop us a comment on YouTube. We will get the links shared that Gareth was then talking about as well. So if you are one of the patients or relatives going through any of what we've discussed, please do reach out. I can't echo enough that these guys are doing brilliant work, and actually support is out there So thank you very much.